Welcome to the Pod Doctors. I'm Dr. Damien Dauphinee. I'm here with my partner,
Dr. Raafae Hussain.
And we are going to talk about chronic wounds. It's a big subject. We'll try to drill it down to the most common ones that we see on a daily basis. We have the New Wound Center, the Wise Healing Center in Argyle, Texas, that we both see patients at. And we see wounds of all types there and have a hyperbaric program there with Dr. Ben Crabb. And so let's get started talking about some of the more common wounds that we see on a daily basis there.
Yeah, so pretty much there's four major types of wounds that we typically will see. Venous stasis ulcers, those are your weeping wounds that we'll see from venous insufficiency. They tend to be very tender. These patients typically aren't neuropathic. And you'll have the shallow ulcer that drains excessively. The biggest thing we want to do here is pretty much control that venous regurgitation, that venous reflux, and hopefully get these to close up. The second most second type of wounds that we'll see are arterial. And these are the ones that are specifically poor blood flow, poor arterial disease, peripheral arterial disease, and that blood flow coming down to your extremities, it kind of tapers off and or gets blocked, and people will end up with these little eschars. There's punched out, deep-seated black scabs that we'll see, and if it's down to the toes, we'll see some gangrene there.
And we're really at the mercy of our vascular interventionalists with those wounds, obviously. We can't do a whole lot until they restore blood flow to the limb.
Yeah, you have to find someone who's a peripheral arterial disease specialist. There's tons of different types of vascular docs out there. They each have their kind of niche, and there's like generalized overviews or jack of all trade type of vascular docs. You have to find someone who specifically works with peripheral arterial disease. Ideal.
And we use both vascular surgeons and interventional radiologists, interventional cardiologists to do this type of work. There's a lot of crossover. The vascular surgeons can do some of the more complex, difficult procedures, but those are really, fairly rare these days. Most of everything that they're doing is endovascular work.
Yeah.
And that can be done by any of those three specialties. And so, but I think finding someone who wants to do and is experienced at doing simply arterial, lower extremity arterial is really important. I think they're clearly going to be better suited for the folks that we have to treat, primarily because if you're opening up a blood vessel that's not going to be a critical vessel for my wound, that may help the patient in general, but it's not going to help me get this wound closed. So putting a stent in an artery that doesn't have anything to do with the lateral malleolus, like in that second picture there, it's not going to really help. So that's where I think finding someone who has expertise in extremity arterial insufficiency is really important.
The third type of wound that we'll see, probably the most common that we'll see, is your neuropathic, aka your diabetic foot ulcer. This is when you have uncontrolled diabetes, you have that neuropathy, you have that poor healing potential, and they end up pretty much walking until they get a sore, typically on the bottom of their foot, on a high pressure spot. And these are things that we're able to take care of if we stay ahead of it, with offloading, simple antibiotic ointment treatments, diabetic shoes and insoles. Honestly, simple stuff. If we can take the pressure off of them and keep the neuropathy under good control and the diabetes under good control, we can get ahead of these. And the last type kind of overlaps on this is your pressure ulcer. These are, part neuropathic, part bedbound. I have a patient right now who's a prime example. He's completely limited to his mobile motorized chair, and he's got a pressure sore to the back of his leg, had one on the back of his heel, literally just from positioning. He was in that chair for so long, and offloading wasn't the ideal when I first saw him. He got a pressure sore. And
most of those folks have some semblance of arterial insufficiency, driving this, right? So most of these wounds wouldn't show up in someone who had completely normal arterial flow. They could have some mild to moderate disease, and then you add a pressure point unremittent pressure for even just an hour or two. So patients who are bedbound or who are immobilized, maybe after a hip fracture repair, some sort of accident where they're relegated to a hospital bed, they're at high risk. And they could have few of the other comorbidities, but just simply the fact that they can't move can lead to this. So that's really important for family members to get involved. When you've got a family member who may have had a hip replacement or a hip fracture repair, who's really immobile, who's going to be spending some time in the hospital, to pay attention to their heels, float their heels, because boy, that posterior heel wound is completely preventable, but you got to be on top of it.
Yeah, the heel, the sacrum, the elbow, these are common spots that we'll see these. If you ever had a patient who's been in the hospital and has a risk for pressure sores, you may see them on air mattresses. They pretty much fill up this mattress. It's a very fancy air mattress, and it literally, the air contours around them and distributes the pressure evenly. Nurses will come by, every shift or every few hours, and they'll roll and rotate them to make sure that the pressure is taken off of any high pressure spots. But there's a lot of different things you can do to kind of stay ahead of these. So this is just a generic overview. We're going to dive, more specifically, and a lot of these will overlap. With diabetic neuropathic ulcers, they're also a type of pressure ulcers, they're also a type of arterial ulcers. I mean, there's a lot of overlap in all of these. You typically don't get one without the other. All right, so we're going to start from the beginning. We have a patient come in, first time seeing them, they have a wound or an ulcer, and we're like, all right, we got to take care of this. So we'll debride the wound, we'll see the full extent of the wound. We'll get cultures, we'll do swabs. We want everything possible while the patient's here at the first visit.
We'll get arterial, at least ABIs, or, palpate for pulses, obviously.
Yeah, if they don't have good palpable pulses, ABIs, TBIs. ABIs are ankle brachial indexes, or TBIs are toe brachial indexes. Pretty much comparing upper blood flow to your lower extremity. If we have limited blood flow, we'll send them to a vascular doctor. If we have elevated more than normal blood flow, it's one of those weird catch-22 type of things. If the reading is too high, we'll also send them to a vascular doctor because the vessels can be calcified and giving us falsely high numbers. So it's like this, we have to have that sweet spot.
And without that, we're not going to get real aggressive with debridement. Obviously, you got a patient that comes in with an arterial ulcer, you're not going to do a lot of debridement on that patient until you've established that they've got adequate flow.
The other thing we'll get imaging. We'll get x-rays. Here I put a picture of someone who has subcutaneous emphysema, aka gas gangrene. One of the type of things you don't want to see in clinic.
Yeah.
That is emergent.
That's an admission to the hospital.
Yep.
Yeah, absolutely.
Yeah, and the other thing we're looking for is bone infection. We have a patient who'll come in and be like, I've only had this sore for a few days, and the spouse will be like, he's had that sore for like 6 months. And these things don't happen overnight. So we'll get the x-rays. We want to see if there's any bony involvement. If there's any concern of bone infection, we want to address that as quick as possible. We're fighting an uphill battle on all of these cases. We have diabetes that's usually uncontrolled. We'll have peripheral arterial disease. We'll have a puncture wound. We'll have a wound that we're catching up on. We don't know what happened, what caused it. I had a patient who actually had a piece of barbed wire fencing in his heel at one point. I mean, it was just like, what is this? And we were scraping, I was debriding, and boom. Lo and behold, we got a little thing popping out of his. I mean, it was pretty big. It was impressive.
I've pulled Legos out of wounds. Patient was walking on their grandkid's Lego for weeks and weeks and didn't know about it till the whole area got infected.
I've actually had 2 patients who've had nails in their shoe and didn't realize it. They're, diabetic neuropathic, and they're like, I don't know where this wound is coming from. I'm doing everything possible. I'm wearing protective shoe gear. I'm taking the pressure off. I'm keeping it covered and blah, blah. And I'm like feeling around the bottom of his insole liner just, to make sure there's no debris and stuff in there. And I look, I'm like, I can feel something on there. And I look at the bottom of the shoe and he's got a nail. Yep. I had 2 patients like that, not even like one.
That's not uncommon.
So we'll do our initial visit. We'll dress it. We'll put some antibiotic ointment. Our primary dressings are pretty straightforward. I'm a big iodine guy, betadine guy. I know a lot of people like to use fancier things. You need something that's going to kill the infection. So iodine is antimicrobial. Obviously, we don't use it for too long because it can be a little cytotoxic. But for initial infections, we want to knock down anything that could be at risk. Other popular things, mupirocin, gentamicin, silvercell, any type of silver-backed dressing is antimicrobial. Hydrophora blue, another silver Mepilex.
You're looking for absorption and then antimicrobial capacity. Absolutely. Some of these are antiseptics. Some of them are antimicrobials. Silver is really an antiseptic, so it works in a little bit different way than an antibiotic. So, but yeah, that initial dressing is usually going to incorporate something that's going to kill bacteria and absorb drainage. Yeah.
Yeah. All of these except the mupirocin and the gentamicin will kill everything. The mupirocin and gentamicin we will use because they're MRSA specific. They'll help kill any methicillin-resistant Staph aureus. But there's other things on the market that kill everything. Mupirocin, gentamicin don't kill everything. So if someone tells you that, or you're using it and your infection is still coming back, and you may want to switch to something that is completely antiseptic, like betadine, silvercell,
and then also.
That's why you take wound cultures.
Yeah, because we may need to attack this systemically, and so we don't rely on topical antimicrobials or antiseptics in a vacuum.
Yeah, and that's the nice part when we do our wound cultures. We'll send them if we're not able to get the infection under control. Like typically we'll put them on antibiotics initial visit when there's concern for infection, and we don't see good improvement. By the second time we see them or the third time we see them, I'll send them over to see our infectious disease guys. We have a couple guys that we've been using consistently, and they're very good, very aggressive, and they get the culture results from our initial visit, so we have no lag time. The patient will come in, I'll put them on Bactrim or Doxy or whatever it might be, depending on the type of infection. And if the infection isn't getting good control, I'm like, all right, this is out of my hands. I need someone who's great at infection control. The ID doc will come in, maybe put them on even some type of IV antibiotic,
I think the other thing to consider too is the diabetic patient who's on dialysis or who has stage 3, stage 4 kidney disease. Mm-hmm. You don't want to be adding medications that are going to be nephrotoxic. And so those are folks that I will bump to the ID guys quicker than usual because they're complex, fragile patients that can get into trouble very quickly. So,
anyone who has bone infection. I will let them take over.
Yeah, because they'll help you manage whether or not this patient needs a 6-week or course of antibiotics. Typically, we're going to take those people to the OR and debride that bone and shorten that course of antibiotics, hopefully to 2 weeks. But yeah, still, it's great to get the ID guys, the infectious disease guys on board. And also just that polypharmacy patient, the patient who's on 16 different medications. And yeah, you can run queries with the database and determine obvious drug-drug interactions, but those guys are so much more adept at addressing those things and picking the right antibiotic based on the other medications that the patient's on. So that's why that specialty exists. They do a good job.
Now, the other thing we want to make sure of is that the antibiotics are actually getting down to the foot. If we have these patients with peripheral arterial disease, if you have no blood flow coming down to your foot, no antibiotic's going to get there.
It's going to be limited.
Yeah.
So, yeah, I think it's got to be, a shotgun approach. You can't just attack one thing. You've got to be able to get them into the right hands of the right folks who can help you improve the blood flow, deal with the infection, and then once we know that we have adequate perfusion, then we can be more aggressive with our debridement. We can really make some differences there and try to turn this thing around before you end up having to cut things off.
All right, so the patient comes back in. The wound is looking better. There's no more red swelling. There's no more infection. So what do we do next? We're not going to do those antimicrobial dressings forever because we're not so much worried about infection. So we'll switch to something fancy. We'll use, I typically will go to like Santal or something like that if it's fibrous, or some type of collagen dressing if the wound bed is nice and beefy, red granular. So here are a couple examples of collagen dressings. Endoform is probably a classic. Promogran Prisma. This is another Helix. The goal being that collagen will be a scaffold for your normal skin cells to grow onto. Now, if you don't have that beefy red layer that we're looking for, and it's like fibrous or wispy or whitish or grayish, that body's trying to heal, but it's making that fibrous tissue, we'll use Santal. Santal is a collagenase. I know Dr. D likes Santal quite a bit.
Yeah, it cleaves broken collagen in 7 different areas. So we have an endogenous ability to produce collagenase, but the endogenous collagenase is limited, and it only cleaves it in one area, maybe 2. But the 7 different areas where you can break down collagen means it's going to break down that slough faster. And I think a lot of folks are using it for, I think specifically to be able to get rid of the detritus that becomes bacteria food. So one of our colleagues, Travis Motley out in Fort Worth, I'm going to give him a shout out because he did 2 really nice studies on this where they looked at how important was it to use Santal to break down debris in the wound bed versus silver, which we know has been used in wound care for decades and kills bacteria. And his studies were showing that there's pretty good evidence to support the fact that getting rid of the detritus and the crud in the wound bed is actually more important. That if you get rid of the stuff that becomes bacterial food, you can basically prevent the infection and prevent the colonization. So I'm a believer in that. I think Santal extends your debridement. So we can do a sharp debridement in the office, keep them on Santal dressings daily, and make that wound look way better the following week. When in some cases, what you end up doing is you do the debridement, and then the biofilm and the crud starts coming back in during the intervening week, and then you're sort of 1 step forward, 2 steps back. So that's what I think Santal is really, really helpful for.
Let me ask you this, Dr. D. What do you think about those docs that like to say, I don't need to use Santal or collagenase because I'm doing sharp debridement every week?
Well, I think one of our colleagues over in Fort Worth, Travis Motley, wrote with his colleagues out there 2 different papers on using Santal and the collagenase. And he was able to show pretty elegantly with these research projects that it's probably more important to get rid of the dead tissue, the broken down collagen in the wound bed than it is to use a silver dressing to prevent infection. So they were able to show that the patients that had the Santal actually did better than those that just had silver dressings.
And that's because that fibrous tissue is food, right?
I think it ends up being bacterial food. Yeah, absolutely. Any sort of detritus in the wound bed can end up being bacterial food. So I think there's a pretty good implication there that it may be more important to clean up the wound bed with something like a collagenase than simply using silver.
Yeah.
So I think the way to think about this is that the collagenase is helping you extend your debridement. You do the debridement on a Wednesday, you have the patient change the dressing daily until the next Wednesday, and the collagenase is continuing to clean up the wound bed, even from damaged collagen that you created by your debridement.
Yeah.
So just laying down that tissue, that layer. And then I think it can help get rid of a lot of the stuff that ends up leading to biofilm. So I think collagenase is really helpful in that regard.
After you got the wound nice and healthy, I don't know about you, I like to use Regrenex. So Regrenex is platelet-derived growth factor. It's pretty much whenever you get a cut on your body, your platelets come through, they clot, they make that scab, but at the same time, they're throwing out growth factors. One of the biggest one being platelet-derived growth factors. So there's a reason these wounds aren't healing. The body is lacking. There's a chronic nature to them, and when we put that Regrenex on there, it kind of pushes them. They're like, hey, look, this is a new wound, this is a new ulcer, hint, hint, nudge, nudge, we really got to close this up, body. And
it's acting on producing neovascularization. So it's helping to attract new blood vessels into the area, and it's one growth factor. Now, it's an important growth factor, and it's part of the whole healing cascade. That's why they picked that one. They're able to reproduce it in a pretty unique way. We can go down that rabbit hole if you want, but that stuff's great. It's been around for a long time. It's been around since like 1996, 97.
Yeah.
So I've been using it for my entire career. And back then, it was really the only advanced therapy that we had access to. So it was unique. Now I think we've got other things that also have growth factors,
and then
we can
some.
talk about, and then some,
Yeah.
and maybe levels, which would be really important for wounds that are struggling on multiple fronts. So
the last one we have on here is MediHoney. So this is a oddball. So this is something that is very old and very new at the same time. So back in the day, back in the day of the time of the Egyptians, people were putting honey on wounds and cuts and sores as sort of their antibiotic ointment. You would do the same thing with iodine and sugar. Same thing, back in the day, you'd make a thick paste and you'd slap it on there, smear it on there. And the way it worked, it's real simple, honestly. Sugar, salt, anything that absorbs water exponentially fast, you put anything on there, you put bacteria on there, you put viruses, yeast, etc. It literally pulls the fluid out of the cells and causes the cells to rupture. It's that same effect as putting salt on steak, and you get that glistening on top from all that moisture being pulled off of there. So MediHoney is Leptosporum specific honey, but honestly, you could probably use any type of honey out there. Don't quote me on that. If you guys get infections, I'm not liable. Just don't listen to me. Right?
I think it's an option.
Yeah.
It's been around a long time. It's cheap, relatively speaking.
Yeah.
So I don't use it very often. I find I'm using other products for similar reasons that I think are more effective. But it's an option. And again, it's rather inexpensive compared to some of the things that we use. But, every day a wound is open, especially in diabetic patients, is another chance for that to get infected. Yeah. So we really need to use whatever advanced therapy that we can get a hold of to get that wound closed rapidly, because the expenses in these wounds are not in the stuff we're using to treat them. The expensive stuff is the amputation, the 6 weeks of antibiotics, the 3 or 4 trips in the hospital. Yeah, that's what really causes financial harm and can rack up huge bills. So I always say this, it almost doesn't matter what we're using from a financial standpoint to get wounds closed. The expensive stuff is if we don't do that well and things get infected and you have complications, those are way more expensive than whatever it is we happen to be using to get the wound closed.
So before we dive into all the biologics, I want to go through everything else basic, because biologics we kind of have a long talk about. So offloading, very important. You can do shoe modifications, you can do felt pads, you can do these fancy insoles where you take the plugs out. I kind of like these quite a bit. Cam boots, total contact casts. There's a dozen different options. If they're bed bound, these offloading pillow boots, Prefo boots, whatever they're called. I don't know if Prefo's a company name.
And some of these, I'm just going to throw out some ideas about some of these. So the peg removal of your peg insoles, Dave Armstrong did a study back probably 10, 15 years ago where they looked at, was it better to take those out under the wound or leave them in place? And they concluded that it was better to leave them in place, because when you take them out, you destabilize the whole construct and the whole thing starts falling apart. So it may be better to leave them in place, that you're getting the same offloading and the thing stays intact. The heel booties, these inflatable or padded heel protectors, I think they can be effective for preventing wounds, but once you have one, you need something that's much more rigid, like a POTUS boot. And the multi-POTUS boots actually have a molded plastic piece that will prevent the heel from touching at all. And they have a bar that prevents you from rocking over. Exactly. And so I think you need to upgrade from something that is relatively inexpensive, but it's probably also not going to help once you've got a wound. I think that's really important. Prevention is by far the cheapest route to go. Obviously, preventing heel ulcers in bedbound patients is what we're trying to do. So I think using those things routinely before somebody has a wound probably has it definitely has a better chance.
Total contact casts
I think are great. I think they're effective at allowing patients to still be ambulatory or walk and stand and still get wounds closed. But if you've got significant deformity, if you've got Charcot foot, you've got dislocations, typical diabetic foot wounds like this forefoot wound are a result of the hammer toes and the loss of the big toe. If you don't address those things, you can get wounds closed with total contact casts, but the patients will recur. The patients will have a recidivism incident where their wound comes right back because you haven't fully addressed the mechanical problem that led to it in the first place. So I think
there's a deformity there. We got to address it.
You may be able to get away with using diabetic shoes and felted foam and offloading, and that's
custom
great.
Orthotics, taking the pressure off, distributing their pressure is good to an extent.
It's worth to give that a shot.
Yeah.
But if you see that wound come back regardless, you've got to refer that patient to somebody who's adept at doing reconstruction, because that's what you and I do for a living. That's why we exist. We can do that reconstruction and prevent those pressure points from continuing to be a threat to the patient, because that open wound in that diabetic patient is as dangerous as colon cancer.
Oh, you wait till I get the statistics.
There you go. Didn't mean to steal your thunder.
We're getting started.
Yeah.
All right. So 25% of all diabetics will develop a foot ulcer in their lifetime. 1 in 4 diabetics. I mean, that is so high.
And you did a fellowship with
Dr. Malay.
With Malay, and he is a stickler for data and this stuff. So I imagine you guys looked at a lot of this stuff.
Oh yeah, he's a statistician also.
Yeah, absolutely.
Everyone knows that. So diabetes, huge risk factor for a lot of problems. Obviously, we're talking about foot ulcers here. A big factor in that is that neuropathy component. If you don't control that neuropathy, that diabetes is literally a building block for infection, a building block for peripheral arterial disease, a building block for kidney disease.
And let's clarify a little bit though. You can't really control neuropathy. You can control the glucose, which can lead to worsening of their neuropathy. Can we reverse neuropathy in diabetic patients? I believe in some cases we can, because a lot of times there's an overlying nerve entrapment syndrome, just like carpal tunnel, happening to these folks, and we can address that surgically. 25% of diabetic patients get carpal tunnel, right? And that same, if not even more, are getting nerve entrapments in the lower extremity that are happening on top of whatever metabolic problem they're undergoing. And that's something we can fix surgically. So if we can identify that subset of diabetic neuropathic patients, most of them are having pain, then we can decompress those nerves, improve their pain, but at the same time make a huge impact on their risk for ulceration, probably dropping it down to 3 to 5%.
Isn't there a couple of studies? I know that you're the study guy on this stuff.
Yes, and there's a massive database that Lee Dellon helped put together with his Institutes of Peripheral Nerve Surgery, where the majority of those of us who were doing this type of work were plugging patient data into this huge database. It's retrospective, it's not prospective, but it shows even in those patients that we are referring to people who do this stuff for a living, these wounds are really hard to heal, number one, and we can make a huge impact on their recurrence or the recidivism of these wounds by decompressing their nerves. And that, I think, is worth its weight in gold, because it's the recurring wounds that are costing lots of money and eventually leading to infection, osteomyelitis, amputations. So
and then aside from diabetes, peripheral vascular disease with diabetes increases that risk 5-fold. I mean, that is huge, and that is a big reason that why we work so closely with our vascular colleagues.
Well, and why we also hammer people about smoking and diabetes.
Oh my God, yeah.
Smoking by itself is bad enough, but when you add diabetes on top of that, boy, you're asking for trouble. It's really, really hard.
All right, so we're talking about a little bit of vascular problems, so I thought I would just throw that in there. There are different type of peripheral vascular diseases that we'll see. The two biggest time are arterial and venous. Arterial being the blood flow coming from the heart down to your toes. Those are the ones that we have that deep black eschar, the gangrenous wounds. They're very
painful.
Yeah, tender and painful.
Unless you have neuropathy, that's a danger zone when patients have arterial insufficiency and they don't know it because they have neuropathy. It's preventing them from feeling it.
Yeah, sometimes before it even becomes a problem, patient will talk about like, oh, I can't walk too far. I get cramps, or I got to stop and rest. I feel most comfortable in my armchair where I can hang my feet down. Yeah. I sleep most comfortable in that.
Claudication. Yeah.
Yep. So, and versus that, then we have like your venous insufficiency. That's when people will end up getting the swelling in the legs. They'll have the varicose veins on the skin. They'll have blister if they're having uncontrolled. They'll have blistering of the skin, and they'll have weeping, sometimes in conjunction with lymphedema. Then that's when we talk about getting some type of compression going, water diuretics. And then obviously seeing your venous specialist for this type of thing.
And some people have a little bit of both, so we got to always, rule out arterial insufficiency in those patients who have both arterial and venous, because if you're going to compress them, you want to make sure they have enough flow to be able to tolerate the compression.
Yeah. So as far as arterial disease goes, we send them to our vascular colleagues. Just a super, blank overview of what they typically will do as far as minor procedures go. They'll go in, they rotor out the vessels. They pretty much have this little directional, I don't know what you want to call it, like a pipe cleaner. It has a shaver on it, pulls back, and it pulls all that muck out of there. And they open up the vessels. I mean, you have your 3 vessels that come down past your knee. At the knee, it splits to 3 branches. And we want to get them nice and open all the way down to the level of the ankle. So a lot of the guys that we'll send to, we know will come down to the level of the ankle, if not further.
And the reason you'll see that behind the knee is that you get a lot of turbulence. And that's the theory behind why the plaque tends to plug up those particular vessels, is you got one main one splitting into 3 smaller, and you get turbulence at those intervening sections. And so that's allowing the plaque to be laid down at a much greater rate. So typical diabetic arterial disease is going to happen behind the knee. You'll get it up in the groin level too, in the SFA or the superficial femoral artery. But yeah, it's a real problem behind the knee, and that's largely due to the turbulence.
If they're not able to get all the plaque and stuff out, a lot of the times they'll go in and balloon, which I think they do almost every time.
Yeah.
And then if it's really bad and it's not just staying open, they'll put a stent there. There's a lot of other things they'll do. I mean, definitely talk to your vascular doctor about it. We're not the experts on that. And then when all else fails, they do a bypass.
And the stent is like a cage that kind of holds the vessel open, and those can get scarred in, and that's usually when they fail.
Yeah. Second thing is venous. So blood flow coming down, arterial, blood flow going back up, venous problems. That's when people will start getting like the varicose veins and spider veins and stuff. And there's 2 major components to your venous flow. There's a superficial, which is the ones that you'll see on the skin, and then your deep. Those are the good healthy ones that lie within your muscles. The superficial ones are the ones that typically will get the squiggly snake-like appearance and end up pooling and eventually opening up when that venous control has started to fail. When you have a vascular doctor or venous doctor, they'll go in and do venous ablation or venous stripping or whatever they do now.
Well, thankfully, it's not a lot of the stripping.
Yeah.
I remember scrubbing those cases as a resident.
And you're like, pop, pop,
25 years ago, and you're basically grabbing the vein with the hemostat and twisting it and yanking it out of the leg.
Yep.
Oh, God, that was a brutal procedure. But now they've got a much more elegant way of doing this. Yeah.
So they'll go in and they'll close off those vessels, allowing them to lie flat so the excess venous flow will go deeper and not lie so superficial.
And they're doing that with radio ablation, so feeding a wire down from the groin down into the larger vessels that they want to collapse, and then cranking up the volume. Sometimes
even after they have that venous ablation performed, they'll still have that sore that just isn't going away. So I've had a couple patients, they get the venous ablation specific to the perforating branches that will come from deep to superficial. That means like if this is the skin and this is your muscles and the vessels coming down and they already ablated the ones that are superficial to your skin, that branch, that bridge that's coming through there is just enough to cause that sore on that superficial surface. So they'll go in literally to that spot and they'll ablate it all the way back to where it goes back to the deep vessels.
And your cartoon's got that. It's showing the perforators.
Yeah.
So you can see those, coming right out of the muscle there. And then that's a really effective way of controlling the edema or the swelling in those tissues on the medial ankle. We call that the gaiter area because it's where a gaiter type shoe, a low boot would touch your skin. And that's the area of tissue that becomes very susceptible to wound. In fact, just bumping that tissue when it's bad enough, the patient can end up with a wound in a few days.
Yeah.
Really difficult to heal. You don't have enough nutrition feeding the skin because of all the swelling, and it becomes a chronic issue that can be very painful.
Yeah. So a lot of times we'll do like compression dressings on these, 2, 3, 4 layer dressings, compression stockings, lymphedema pumps, your diuretics, and then obviously working really closely with your vascular doc. Elevation, obviously, a big component to this. Hyperbarics. So, I mean, I know you've been doing hyperbarics since the get-go.
I got trained in this 25 years ago. It was part of my residency as well. So we do use this, and we have access. You and I both have access to Dr. Crabb in the Wound Center, the Wise Healing Center in Argyle, and we have 3 monoplace chambers there. It's an adjunct to a lot of really difficult wounds that we encounter. It's great for soft tissue radiation necrosis for patients who've had breast cancer radiation, other types of radiation to treat other problems. That tissue becomes permanently scarred, and you can improve it by using HBO. Hyperbaric oxygen treatments can make that dead tissue area or that area of the wound or the tissue that's been irradiated look more obvious to the body, and then hyperoxygenating all the cells around it starts that neovascularization cascade where you're growing blood vessels into that tissue to beef it up again. Then surgeons who need to do breast reconstruction, for instance, can operate through that tissue and not have it break down as easily. We use it also for radiation cystitis in bladder cancer patients. They can have a very painful form of bladder irritation that does very well with hyperbaric oxygen treatments. In our realm, we can use it for crush injuries, which I don't think we use it enough for that, but we don't get those crush injury patients from the ER as quickly. So if you're an ER physician and you're watching this, hey man, HBO is a slam dunk indication because it prevents reperfusion injury. So we can super oxygenate those tissues that have been crushed and prevent some of the secondary damage that happens when blood flow returns to that tissue, just like in the heart muscle after a heart attack. Reperfusion injury can be just as bad as the original insult. We use it in diabetic foot ulcers, Wagner 3 and Wagner 4, which is a depth measurement primarily. So Wagner 3 would be a certain depth, full thickness down to, well, not necessarily to the bone, but full thickness and inflammation. So Wagner 3 doesn't necessarily imply bone. That's one of the problems with the Wagner system, is it's not specific enough for that. Wagner 4 would indicate that you've got gangrene. Yeah. And so, we can use it in those situations because it's been proven to be helpful in diabetic wounds of that sort. And then in osteomyelitis, recalcitrant osteomyelitis. So patients who've already had surgery, who've already had a round of antibiotics, and their osteo either comes back or you can't get wounds healed over areas where they've had the osteo. That can be an indication. Those are the main ones. Acute arterial insufficiency is another. So if a patient's had replantation of a digit and they're getting a dusky appearance, they can undergo HBO for that. And then flap failure is another big one. So if you've got a flap that you've rotated into place to close a wound, and the flap gets dusky or gray, and it's got venous congestion, you can address that by getting them into the hyperbaric chamber because it's one of the only things you can do to cause constriction of blood vessels and hyperoxygenation at the same time. It sounds weird that you can do both. Well, how are you getting more blood or more oxygen to the tissue when you're constricting blood vessels? Well, it's reducing edema at the same time. So you're getting rid of all the edema that's preventing the movement of nutrients and oxygen into those tissues. So Very effective adjunct. It's not usually something we do all by itself, but a very effective adjunct.
Yeah, and the way it works is very straightforward. It's a chamber, it's a dive chamber, it can be a room, and we put you into it, and it's increased to 2 to 3 times the natural barometric pressure, and we saturate that entire chamber with 100% oxygen. What we're breathing right now is close to 21% oxygen. When we get it to 100%, all your red blood cells are saturated with oxygen, plus the plasma coming down to all those wounds and everything. So you're bringing all that nutrition down to those wounds, getting that angiogenesis, that new vessel formation, and now we're hopefully healing these wounds up that much more faster.
And yeah, you're bringing in the highlights for sure. Oxygen is required for your antibacterial aspect of your white blood cells. Yeah, your white blood cells can't kill bacteria without it. The angiogenesis component, again, is that same thing we talked about with soft tissue radiation necrosis, where you've got a wound that's a relative dead space. There's not enough oxygen in that area. It's a chronic wound. If you super oxygenate all the tissue around it, it makes that wound look much more obvious. So then it reinstitutes the wound healing capacity of your body. And part of that is growing new blood vessels in to fill that dead space.
Yeah.
Stimulation of growth factors, synergistic with antibiotics, synergistic with Regranax.
Yeah.
Definitely. So I think we found those two work really well together.
I've also read that a lot of high-level athletes will have one of these in their home, and they'll do that after they'll play a game or train or whatever to recuperate and get that much.
They're not using the one that we've got. Yeah. They're not getting to 2.4 atmospheres because you can't just like jump in and out of those. So yeah, that's a lesser version. There are also versions that are simply designed for the extremity, and again, that's not the same thing. You're not getting to 2.4 atmospheres. You're not getting the benefits of actually using it systemically. Yeah. You will get some oxygenation of the superficial layer of tissue, and in some wounds that probably is helpful. But that's very different than what we're doing with true hyperbaric chambers.
Those are the ones that you see that they're on a little machine with a bag around their arm or leg or whatever.
Yeah, it's circulating oxygen basically at atmospheric pressure that we feel now, and you're only going to get so far with that.
Yeah. Wound vacs. So I love wound vacs.
Oh yeah.
I'm probably a little bit on the aggressive side with my wound vac therapy, but it works. It's one of my favorite things. How does it work?
If you took this away from me and HBO, I'd be upset. Yeah, because those two things we rely on, they are synergistic again and can work with each other. But yeah, you took those two things away from me and wound care, and we would be in big trouble.
So wound vacs we'll use when the wounds are starting to look a little bit better, the infection is under control, and what it does, it's a negative pressure vacuum that we pretty much fill just smaller than the wound size, and we put a sponge in there which makes sure that it pulls evenly, and it pulls that wound to constrict and close. The benefit of that is it reduces local edema, so all the small excess fluid that you have around that wound will get pulled out into that wound vac. It's pulling infectious material off of the wound bed and putting it into this canister, and it's promoting perfusion. It's literally pulling vessel formation to that site.
It's
stimulating vessel formation.
Yes, because it's that micro strain. It's that tug and pull that's causing that granulation tissue to be formed. And let's be completely clear here. What we're talking about is negative pressure wound therapy. Wound vac is actually a proprietary name.
Oh, is it?
Yeah.
I actually didn't know.
So it's NWPT. So we're talking about negative NPWT, negative pressure wound therapy, is just the generic term. And there are a number of companies that have negative pressure wound therapy devices. One of them happens to be the wound vac, VAC, but that's a proprietary name. So there are a number of companies, again, that have versions of this type of technology. It's been around for 20 years at least, if not a little bit longer. And it's great for filling deep wounds. I go back to some of the stuff that we did when I was working in wound centers in Chicago when I was a student. And these big, horrible sacral wounds, we were basically coating Curlex with Silvadene and using that to pack into these massive wounds. We wouldn't think about doing that today because we have the wound vac, and it's much more effective at generating granulation tissue and helping to prepare the wound for closure.
Yeah. So when we get a nice healthy wound, I mean, the wound vac is my go-to. I'll do the wound debridement, we'll get them nice and bleeding, and then if I can, I'll put a graft on there, some type of biologics. It can be a simple collagen scaffolding, or it could be some type of umbilical cord graft or then some. We'll put some type of non-adherent backing to it, and we'll fix it into place. This person here, staple into place, you can suture into place, you can steroid into place. And then after that, we'll put a foam on there, and I typically will frame my wounds. I'm just cautious that way. And then we'll put that wound back on there. One, you're getting total contact with that graft on there. Two, you're promoting that great healing potential, and it honestly expedites that wound healing, filling that defect, and hopefully getting that closed up nice and quick.
Yeah, any type of wound that you can't close completely in the OR, this is great.
They even have incisional vacs now that we use occasionally.
That help pull fluid off of the incision. I think for doing split thickness skin grafts, vacking over those is fantastic.
Oh, yeah.
You get those things taken much easier. There's a ton of uses for this technology. And I think in this area, we're talking posterior heel over the Achilles.
Oh, yeah.
And this can just be a killer for trying to get these wounds closed. And doing a good debridement and then doing exactly what you did, put on a biologic, slap the vac over that. That's an extremely effective way of making sure that closes in a reasonable amount of time.
Yeah. One of my favorite therapies. I think it's tried and true.
Oh, yeah. I literally would cry if you took that away from me.
All right, so biologics, since we were talking about biologics and simple collagen dressings, there are so many on the market right now. And I think they're going to start getting weaned off from what we hear. Medicare is going to do a clean sweep and start making these guidelines and stuff.
I like to say that there are companies that come in the office with a book of pretty pictures, and they show all these wounds that they've been able to close, but they don't have any data backing their device or their stuff. And I think those companies are going to start to fall off because I don't think they're going to be able to survive without showing the data. And several of the companies you have up there have done research and have proved that their products are worthwhile. So that's what you got to do in this game to be able to prove that your claims are legit and that your device or your product is helping to close wounds faster than they would close otherwise.
So we can start old. So Integra used to be like the gold standard as far as ideal grafts biologics go. Silicone backed, it had great healing potential. It had collagen. It had all the building blocks for your wound to heal. But then as we've gotten further along with our sciences,
I still think that is fantastic for the full thickness degloving injuries, where you've got exposed tendon and exposed nerve, exposed vessels. The quickest way to get some coverage over that, I think that is still a tremendous product, because you can staple that into place over a big degloving injury where tissue has just been stripped off, either with a motorcycle injury or, I even had a guy when I was a resident who was dunking a basketball and he had his wedding ring on, and it ripped the wedding ring off, took all the tissue over his finger right off. And we used that for that particular patient when I was a resident. So I think for that type of wound, it's still really effective. And you can either go back 3 weeks later and do a very thin split thickness skin graft over that, or you can then switch to other products that are, skin graft like, or a skin substitute like.
Yeah, I know I've done a couple where, they don't come meshed, so you just kind of poke a dozen holes with your blade into it, and then I'll stitch it into place with an absorbable stitch, and then put my wound vac on top of it. So you're getting that wound vac to heal it. You got all the wound graft stuff pulling it and hopefully closing that up. And then the fun part is when eventually, once the stitches absorb and or dissolve, and by then the wound is stable enough, about 3 weeks out, and that silicone layer just kind of peels off, and you got that nice, hopefully healthier wound bed, if not healed up for a good portion.
It's basically creating allowing your body to create a new dermis.
Yeah. So something a little bit further beyond that is your Epifix or Mimetics type grafts. Very, very good. It's still one of the better grafts out there. They are dehydrated amnion chorion. Amnion chorion are layers of your placenta. Membrane sheet grafts. They are processed using some proprietary Purion processing method, which protects a lot of the growth factors and things that allow that wound to hopefully heal up nice and fast. Still one of the gold standards as far as wound grafts go. I know you use that quite a bit.
Yes, we've used it on a number of patients over the years. It's a tremendous product. They have some good science backing it. I think they're gonna still be around after all of these other smaller companies end up going away. I still lean towards living tissues and the stuff with cells.
That's why I like this.
Things like Neox 1K graphics. We've been using the Neox 1K product to wrap nerves, and I'm coming to understand how important this heavy chain hyaluronic acid pentraxin 3 molecule is. I think they've shown that this is part of the fetal healing process, and that's why fetal surgeries can leave no scar. We always say if you could bottle the healing that happens in utero, you could bottle that and make $1 gazillion. So I think at this point that graft is really helpful because it's retaining that hyaluronic acid, heavy chain hyaluronic acid molecule. I think there's a lot of really interesting science behind it. And again, we're using it to wrap nerves to prevent scarring. There's an anti-inflammatory component to it that's very powerful as well. And I think we're seeing the patients that we do this on, their wounds are healing in a very unique way. They look 6-8 weeks older than they really are.
Yeah, they heal up with 1 or 2 grafts. I put the part of the study in there just because I thought that was important, because everyone has a graft. Everyone can actually make your own graft if you wanted to. There's tons of stem cell, what are they called? Placenta, whatever companies out there that you can.
They're a dime a dozen. There are a ton of them.
Label your own name. Yeah, I want a Hussain graft. Fine. I'll, buy a company that makes a name.
But I agree with you that it's really, you've got to be able to produce studies that are going to elucidate why this device works, why it's important, and I think the folks behind Neox 1K Biotissue have got some really good, interesting studies out there.
Yeah. All right. So, general overview. We already talked about this before, but the number of chronic wounds are increasing per year 12%. 25% of diabetics will develop a foot ulcer in their lifetime. 15% of diabetics with a foot ulcer will require an amputation. Once you have an amputation, a major limb amputation, 15% of those will get the opposite limb amputated within 5 years.
These are scary.
50%. I think I said 15. 50%. And I think, if I'm not mistaken, that number has gone down to 3 years. Don't quote me on that, but I'm almost certain that number has increased.
It's getting worse.
Yeah, it's not getting, because the number of diabetics with uncontrolled diabetes and chronic wounds are just increasing.
Well, and the Texas Diabetes Council was estimating that at the current rate of diabetes in Texas, that 1/4 of the state will be diabetic by 2040. So that's a scary stat.
My God.
You see 8 people walking down the street and 2 of them have diabetes, no matter where you are in the state. I mean, that's amazing. I think we're going to be dealing with the repercussions of diabetes for generations unless we can find a way to fix it. I don't see that on the horizon right now. So we're dealing with those folks that have the neuropathy, who have the deformities that are leading to these wounds. That are limb threatening, and again, they've been shown to be as dangerous as colon cancer in that population.
There we go.
There you go. Boom. Yeah.
Neuropathic ulcers, amputations, ischemic ulcers, your neuropathic ulcers, your diabetic ulcers, they're on par as colon cancer, so even worse at some levels.
Yeah.
I mean, that's the top, one of the top 4 mortality rates. I mean, it's
and one of the things that they've looked at in the past is, okay, so why are we getting so good with prostate and breast cancer? We've got protocols that people are entered into, and most of the time they're going to do pretty well. We still have lots of different specialties doing wound care, and lots of people who have variable degrees of expertise in wound care, and that can make things less than optimal. And that may be one of the reasons why we're seeing those wounds become such a problem, and lead to more morbidity and mortality that maybe we could avoid.
I think a big component of that is that neuropathy. I mean,
of
it
course,
sounds silly, but they don't feel the pain. They don't worry about it because it's not painful. You stub your toe, you're like, all right, I think I broke my toe, game over. When they have that neuropathy, they stub their toe, they keep walking, they don't even think about it. They get a splinter in their foot, don't worry about it. If you or I got a splinter in our foot, we'd be hobbling for a couple of days. It's a big thing when you don't feel, when you're insensate.
Oh, there's no doubt. And then if you've got deformity, even something as relatively benign as a hammer toe, on top of that neuropathy, you're setting up a situation for that patient to get a simple callus that becomes an ulcer, gets infected, and the rest, this cascade effect. So yeah, I think a lot of this is important. So yeah, this ADA consensus development conference on diabetic foot, we quote this a lot, and they're talking about that unhealed wound that's not showing signs of healing for a 4-week period. You got to change gears. And so if you're not doing something different after that 4-week period, you're definitely going to see complications out of that.
Yeah, we tell patients the goal is shrink it by half within that first 4 weeks. If we're not seeing that improvement, we're getting fancy. We're getting everyone and anyone on board that can take care of this.
We're going to change tack. And unfortunately, this is still the case in this day and age, that the third-party payers often dictate, and they say they don't practice medicine, but
they limit medicine.
Yeah, we really have problems with some of them, particularly, that are making it harder for us to do our job, which is try to save limbs, and that can be really frustrating. So sometimes we're basically dictated to what we can use and when. But typically, the majority of the third-party payers out there are going to follow. If you've got a wound that becomes chronic, that definition is usually it's not closing by 50% within a 4-week period. Because if it's not, it's only got about a 3 to 5% chance of being closed at 12 weeks. Yeah. So that's a pretty black and white picture.
It's hard stats.
Yeah, and those stats have been replicated over and over with tons of studies over the last 20 years. So the nice thing is there's a nice bevy of data to prove that point. So
this is courtesy of Dr. D. These are his patients. He had that lecture that you presented on. So we pulled a couple of these cases. 55-year-old male with loss of protective sensation with diabetes. Infected callus submet 1, that's under your first MPJ. Initial treatment IND, removing all the necrotic tissue, exposing the long flexor hallucis tendon, and then the attempting surgeon to use that bilayer living skin equivalent failed to improve the wound bed. Is that you, the attempting surgeon?
No. Oh. So that IND is incision drainage. So this was, clearly back in 2008.
That's the tendon right there.
So yeah, you've got deep tissues exposed. You don't need to staple most of these things in, but this wound probably just wasn't ready. This really needed more debridement, more time, offloading, maybe a vac. And so they may have jumped the gun a little bit by using the bilayer. We're trying to stick with non-trade names as much as we can, but yeah, this bilayer tissue I think is effective, but they may have jumped the gun here. So anyway,
you need beefy red tissue.
We took all that stuff out. We took the staples out. We debrided the heck out of it, and you can see we got the patient into the hyperbaric chamber. We started using a cryopreserved version that is a dermal cryopreserved monolayer product, and then vacked over that with HBO, with hyperbaric oxygen treatments. You don't have to do just one thing, wait till that fails, and then do one thing again. You can do all three at the same time. And for wounds like this that are threatening this guy's limb, that's what you got to do.
We were able to moving parts.
There's a tiny little area of exposed flexor tendon there, but that flexor tendon still looks healthy. So that's not tendon we have to excise. We just need to get a little more granulation tissue over it. But that's a pretty short period of time. And now we've granulated the whole thing.
April 9th. Let me go back. Yeah. March 5th.
So about 5 weeks.
Yeah. And I mean, I would say it's about close to half the size. I mean, look this is the big toe joint right back here. Your wound is all the way back here.
Oh, yeah. Yeah, that was a dangerous wound. And then when you go one more down the line.
Look at that.
May 21st, healed up. So that did not require another trip to the operating room. We were able to control that right there in the wound center.
So another one, neuropathic ulcer, 38-year-old, diabetes type 1.
Yeah, previous partial hallux amp in college. I remember this guy. He was a really nice guy. He was dealing with type 1 diabetes since he was a teenager.
Yeah, that's the worst.
Yep, was a college tennis player and would drag his foot on the serve. He's starting to get neuropathy, ended up with a wound there that got infected. He got osteomyelitis or bone infection and ended up with a partial big toe amputation. And so now he's dealing with a wound underneath the metatarsal head in that same area. For over a year, a colleague of mine was treating him with the Kaplan gel, local wound care, and I think some of the things that were missed were the offloading. So we got him offloaded on crutches or a knee scooter, and we started applying the dermal matrix, the cryopreserved dermal matrix. And you can see this is January 29th.
Yeah.
So we started applying on the 29th of January. Flip through the next couple of pictures, and you can see this thing zipper up really quick. So now we're at February 5th, February 12th, February 19th. Boom, healed. And at that point, I'm like breaking my shoulder trying to pat myself on the back, right? I'm like, oh, I'm the best wound surgeon ever. And the guy goes about 4 weeks and he re-ulcerates completely.
Oh, no.
And so I'm like, okay, geez, what did we miss? And if you go back, I think I put the picture back in here, so it's beautiful. But then he gets it back again, because if you go back to the very first picture, this guy had diabetes, again, type 1 diabetes. He had been dealing with diabetes for a long time. Go back one more picture. This picture. He had wicked equinus. His range of motion at his ankle was impaired tremendously by a tight calf, tight Achilles, probably glycosylated Achilles.
Yeah.
And he couldn't even get to neutral. So he spent all day on the ball of his foot and would just crush right through this tissue. So it wasn't until we lengthened his Achilles and got the range of motion back at his ankle that we were able to prevent recurrence of this wound.
Yeah. How aggressive have you gotten as far as when you're dealing with diabetic with wounds or any type of amputation? How aggressive have you become with lengthening the Achilles?
Every time. I mean, I think if you're going to do a transmetatarsal or midfoot amputation, but even these forefoot wounds, a gastroc recession, where we go up and just lengthen the tissue above the Achilles, is really helpful at eliminating the forces that are leading to this type of wound in the first place. So this is the perfect example of, you could use whatever magic fairy dust you want on that wound, but until you fix the mechanics, you haven't really done anything for this patient. And I learned that the hard way by missing the equinus on the front end. And so thankfully that was 2003. And so I've learned a few things since then, thankfully. You got one more here?
I think this is our last one. Okay. So post-amputation ulcer. Elderly, poorly controlled diabetic with loss of protective sensation, complications of delayed healing after a recent 5th toe amputation. It looks like it was a partial met also. But
well, no, that just, the whole thing fell apart on the surgeon, and he sent them right over because he was like, geez, what are we going to do here?
Yeah.
This guy clearly had vascular issues.
Yeah.
And we needed to work him up from that standpoint.
So this is February 6th here.
Yeah, we did a very extensive debridement, rongeur, scalpel, removed all that dead tissue, cleaned it up. got him cleared from a vascular standpoint, and then I believe we got him into the hyperbaric chamber.
That's the same day,
quickly.
February 6th.
Yeah, so that's pre and post debridement. That's a good debridement.
Yeah.
That's clearing those wound
before
edges.
All that fibrous tissue, all that fluffy tissue.
Go. Yeah, you can't dink around with that.
Yeah, and it looks like you took a piece of bone out too.
Yeah, we took some of the fifth met, just right there, right there in the clinic.
So got the negative pressure wound vac therapy going, hyperbarics, and just seared debridements.
Yep, initially that's what we did, and so you can see this thing starting to granulate in with the help of the negative pressure wound therapy.
So whenever you got a pocket, whenever we use negative pressure wound vac therapy, I'm assuming you used white foam for the deep pocket, or hydrophor blue.
I believe we probably did. Yeah, white foam, and then maybe, and then we also will bridge the track pad to the top of the foot. You can kind of see the indentation there. You don't want to put the track pad on the side or in the bottom of the foot.
It has a little rubber nub to it for most companies. Aside from one, Smith & Nephew one, which I try to use as much as I can, the other ones have a rubber nub. So when you have a wound on the bottom of your foot or the side of the foot where it could be a pressure spot, you have to first do your wound vac like you normally would, and then you do a bridge to the top of the foot, and then you put that sponge or whatever, that suction.
And that works great. And that's what we've done for years. So it's not a huge issue. But yeah, that granulated in really beautifully. And then I think we then transitioned to, so we started using a living skin equivalent collagen scaffolding product to get this to epithelialize. And you can see, it epithelialized in really nicely. And then we were able to keep that guy into diabetic shoes and prevent him from reulcerating. So
in about 3 months, I mean, look at that.
That's not a bad.
That's phenomenal.
That's pretty typical. So that's not an outlier in a good way. So that's good.
Well, I mean, that's all we got for chronic wounds. I don't know if we missed anything.
Yeah. Thankfully, I think we've got lots of different tricks in our bag to get these wounds closed. The Wise Healing Center in Argyle is a great facility that we are seeing the majority of these difficult wounds in, with the help of all the fantastic nursing staff that we have there, and Dr. Crabb doing the hyperbaric oxygen treatments for us. So it's a great place to work. I know you and I both have enjoyed working there, and hopefully it'll be a part of the community for decades to come. Very good. All right. Well, that was a pretty deep dive, bro.
Yeah,
if we got people that stuck around for the whole hour, I'll be impressed. But hopefully you did. Hopefully you learned something from our deep dive into chronic wounds, and we will see you next time on the Pod Doctors.